Hi, my name is Colleen Campbell, and today we're going to talk about the RUSH exam, which is the rapid ultrasound for shock and hypotension. The RUSH exam was first conceived in 2006. It's a combination of previously described uses of critical care ultrasound and actually can be completed in 2 minutes. This rapidly narrows down the differential in hypotension and shock. So why should we use it? There's some pretty good studies that tell us why. Jones and Tayal did a randomized control trial of immediate versus delayed goal-directed ultrasound to identify the cause of hypotension in emergency department patients. What they found is using the RUSH exam narrowed down the differential diagnosis to 4 versus 8 in the delayed ultrasound group. People were led to the correct diagnosis in 80% versus only 50% in the delayed ultrasound group. What the RUSH exam consists of is a HIMAP, or looking at the heart, the IVC, Morrison's, or the FAST exam, the aorta, and the pleura. I like this clip as an example of most of these things, because here we see the diaphragm, here we can look at the liver and a piece of the IVC and assess volume status. Here we can look at the aorta and a long view axis as our backup view. And here we see a piece of Morrison's pouch most posteriorly. In this view, our marker dot is up in the mid-axillary line on the right. When we look at the heart, we can look for pericardial effusion or tamponade using the parasternal long axis. What we're looking for in tamponade is right ventricular collapse in early diastole or right atrial collapse in late diastole. To look for RV failure, pulmonary embolus, or RV infarct, we're going to use the apical 4-chamber view. McConnell's sign is quite specific for pulmonary embolus, and it consists of decreased movement of the right ventricle with apical sparing. And we'll show you an example of that later on. The ejection fraction can be assessed using the parasternal long axis view. We are looking at a hyperdynamic heart if we see more than a 90% change between systole and diastole. This predicts fluid responsiveness. We can also look at the anterior leaflet of the mitral valve in this view and see if it comes up and hits the septum, signifying a pretty normal ejection fraction. In the parasternal long axis view, we're going to use the phased array probe. We're setting in the cardiac preset, and we're going to place our probe in the 3rd to 4th left sternal border space. The marker dot will be from the right shoulder to the left hip, and we will see the aortic outflow tract above the left atrium. Here's an example of where we're going to put our probe on the parasternal long axis view. We're going to put it in the long axis of the heart just at the edge of the sternum on the left, and we will be able to see the mitral valve, the anterior leaflet of the mitral valve coming up and hitting the septum. We'll also be able to see the aortic outflow tract with the aortic valve, and on top we will see the right ventricle. This is an example of a nice parasternal long axis view with a normal ejection fraction. We see that the heart is globally squeezing normally. We can look at this anterior leaflet of the mitral valve and it will come up and hit the septum. We see that the left atrium is approximately the same size as the aortic outflow tract here. And finally above we catch a piece of the right ventricle. This is another example of a parasternal long axis view of the heart. Again, we see a nice ejection fraction with the anterior leaflet of the mitral valve coming up and hitting the septum. We're going to see the whole left ventricle here and the right ventricle here. This is a different looking parasternal long axis because here we see that we have the left atrium and the mitral valve, a little bit thickened walls in the septum especially, and this is the aortic outflow tract. And then the next thing we notice is the right ventricle, and then this pericardial fluid, which we can trace here. Now, if we see fluid in between the descending aorta and the heart itself, then we know that is true pericardial fluid. Pleural fluid, on the other hand, will track not in between the descending aorta and the left atrium. Pleural fluid will track up to the descending aorta, but not in between here. So in this example, we probably have a bit of both, but we definitely have a pericardial effusion and likely a pleural effusion as well. This is another example of pleural and pericardial fluid. Here, we're trying to get a subxiphoid view of the heart, and what we notice is we see fluid here, we see fluid here, and we see fluid here. So this is the heart, and this is the pericardium. This is a subxiphoid view of the heart. So this is the right ventricle, the left ventricle, the left atrium, and the right atrium. And this is the pericardial effusion, which is not hemodynamically significant. On the other hand, here we see what should be where the liver is, but again, all we see is fluid, so that is subdiaphragmatic fluid and a piece of the liver popping into view here. And this is pleural fluid, and we see a piece of the lung plopping into view here. So what signs do we look for on ultrasound for tamponade? These echocardiographic signs accompany clinical signs, but actually these may precede clinical signs of pericardial tamponade. So echo findings of cardiac tamponade include a moderate to a large pericardial effusion, right atrial early systolic collapse, right ventricular early diastolic collapse. There's a lack of respiratory variation in the inferior vena cava and hepatic veins, and we may see a bowing of the intraventricular septum into the left ventricle. And here, when we look at this, we see a lot of pericardial fluid here, and we see a bowing of the right ventricle here that partially collapses in early diastole. Here we see posterior pericardial fluid, which is always abnormal, and we see the left ventricle here. We have a very big right atrium as well seen in this view. Here's a very large effusion we see on a subxiphoid view, and again we see that the wall of the right ventricle tends to collapse into the right ventricle in early diastole. This pericardial fluid comes all the way around here and all the way here anteriorly. So why we look at this view is we're actually looking at a parasternal short axis view at the level of the aortic valve. So it's a slightly superior view than the mitral valve. And why we look at that is what we're trying to see is, do we have collapse of the membranous septum of the right ventricle in early diastole, and that would signify tamponade. And it looks to me like we do have some collapse, and this would be somebody who would need more acute management of their pericardial fluid. So this again is going to be the first area in the membranous septum of the right ventricle that we will see collapse of the right ventricle if we have tamponade. This is a video of someone doing a pericardiocentesis, and you see the electrical alternans here in the EKG. And they're just going to come in to where they see the fluid, so look up here for the needle, and look at the collapse of the right ventricle here. This is that membranous septum of the right ventricle. and they'll put their needle just underneath the probe. This again is the electrical alternans. And they'll put their needle right in here to come in and right in here. So right ventricular failure can happen for a number of reasons. One can be acute pulmonary embolus. One can be RV failure or infarct. And we usually say in adults the right ventricle should be about 60% of the left ventricle, but that is age-related. So at birth, the right ventricle will be comparatively bigger, 0.8 to 1. At 1 month, the left ventricle becomes bigger, 1.5 to 1. And at 6 months, the left ventricle is 2 times as big as the right ventricle. And by adult, it can be 2.5 times as big as the left ventricle. So let's talk about the apical 4-chamber view of the heart. We're going to use the phased array probe again. We're going to be in the cardiac mode. Our marker dot is going to match what we see on the screen marker dots. So whatever side of the screen the marker dot is on, you will match your probe so that it looks the same. In the end, the left ventricle should be on the right side of the screen, and the descending aorta should be seen right next to the left atrium, and that's a good way to tell which side is left and which side is right. We're going to start at the PMI, just below the left nipple, and we're going to angle our probe left to right. The septum should be upright. So this is where we place the probe for the apical 4-chamber view, and this is what we're going to see on the ultrasound. We'll see the left side of the heart on the right side of our screen, and the right side of the heart on the left side of the screen. And we want the septum to be straight up and down, just like this. So here we see the descending aorta, we see the left atrium, and we see the mitral valve coming up and hitting the septum, which signifies a normal ejection fraction. We see the left ventricle here and the right ventricle here, and this is the right atrium. And again, we want the right ventricle to not be more than 2/3 the size of the left ventricle. Here's an example of a descending aorta right here, left atrium, left ventricle, and we can see that the right ventricle here is about as big as the left ventricle, and that would be enlarged. We also see here that we have some LVH in this heart. This is an example of a dilated cardiomyopathy. We don't see the left atrium well here, but what we do see is this heart is barely squeezing at all, and we have a very dilated right ventricle. And then here's the right atrium. So this person is probably getting close to getting an AICD and an LVAD. This is a young person actually who I saw who is only 21 years old and came in short of breath. And what I found, I just decided to take a quick look at his heart, and what I found was this mitral valve was coming nowhere near the septum, so he had a very low ejection fraction. And this was part of the reason why he was short of breath, is because he had acute onset of heart failure from blowing out his heart using methamphetamines. And then we see here almost swirling of the blood in the right ventricle, that the ejection fraction is so low. So this is another good reason to go for a run and not use methamphetamines. This is an example of a patient who also came in very short of breath, and Dr. Mintz helped do this ultrasound. This is the left heart, and this is the right heart, and what we see here is the right heart is heaving. It's as big as the left heart, and we don't have any ventricular hypertrophy, so we know that this is a pretty acute process, and this patient had a giant pulmonary embolus. This is an example of McConnell's sign, and what we'll see is actually we'll see that there is apical sparing, so the apical part of the heart will beat, but the right ventricle won't beat well otherwise. So this is apical sparing in acute pulmonary embolus. And I'm just going to let you guys watch this one more time. Watch the apex of the heart here will beat normally, and this part of the heart, you don't see it squeezing in at all. And again, you have a dilated right ventricle. So this is McConnell's sign. It's specific for pulmonary embolus. Next, we have an example of pulmonary hypertension. And what we see here is, first of all, we do notice some pericardial fluid. And this is the descending aorta with its best friend, the left atrium. And we see that the mitral valve comes up and hits the septum. Even though this left atrium is dilated, we see that this mitral valve is coming up and hitting the septum. And then we see a very large, thickened right ventricle, which is consistent with pulmonary hypertension. So we have pericardial fluid, we have pulmonary hypertension in this patient, and the left-sided ejection fraction is relatively normal. Here's an example of right heart failure, and again we see this swirling in the heart right in here, which signifies a very low ejection fraction, and that's a dilated chamber in the right ventricle. So ejection fraction, I like to estimate ejection fraction in the parasternal long axis view, if this view is obtainable. And we watch the anterior leaflet of the mitral valve come up and hit the septum. If it's very hyperdynamic, this predicts fluid responsiveness, and there's a greater 90% change between systole and diastole in the ventricular size. If we eyeball it and say, it's not as bad as it could be, but it's not as good as it could be, that's moderately decreased, and the EF is probably somewhere between 30 and 50%. If we really don't see much movement out of that anterior leaflet of the mitral valve, we say that the ejection fraction is severely impaired and it's less than 30%. Here's an example of a normal EF. We see the anterior leaflet of the mitral valve coming up and hitting the septum. And sometimes if you don't quite see it yet, it's an angle change in your probe of maybe 5 degrees where you'll see it actually come up and hit the septum. Next, we see an example of somebody who needs an AICD or LVAD because their mitral valve is just not doing a lot. They have a very dilated left ventricle and a large left atrium. So this is a dilated cardiomyopathy with probably an EF somewhere between 10 and 15% maximum. So what about the inferior vena cava? What we'd like to do is get a subxiphoid view of the heart and then just turn your marker dot 90 degrees clockwise or up. If you're in the cardiac mode already, then you're going to turn your marker dot down. You're going to use the left lobe of the liver as an acoustic window and start with your probe angled slightly to the right. What you'd like to do is catch the inferior vena cava about 2 to 3 centimeters from the right atrium after it has given off the hepatic veins. The question is, does this actually correlate with CVP? And the answer is, not perfectly. None of these measurements are perfect. The CVP isn't a great measurement of volume status. Some of the newer studies are saying maybe if you put the feet up and see if the IVC changes, that may be a better prediction of fluid responsiveness. But what we're generally looking for in the inferior vena cava is we want to see it collapse about 50% with respiration. If it collapses entirely and it's less than 1.5 centimeters, that predicts a generally low CVP, and that's worth giving this person a fluid bolus. If it's more than 2.5 centimeters and has minimal change with respiration, then we say the person is probably volume overloaded and we will hesitate to give them fluids. Anything in between there is less accurate. So this view, again, is my favorite view in the body. This is with your marker dot up in the mid-axillary line on the right side of the body. And I like this view for so many reasons. A, I get to look at diaphragm, and I can look for that mirror image window in the very posterior aspect of this view, and that's going to tell me whether or not I have pleural fluid. B, I'm going to be able to watch the inferior vena cava come in to the abdomen and give off the hepatic veins, which divide the liver up into its anatomic lobes, and I'm going to get a peek at the fluid responsiveness of the patient. See, I can get a look at the aorta and get a rough estimate of whether it's normal size or not, at least in some portion of it. If I angle my probe really posterior, then I will be able to see the kidney and Morrison's pouch as well. If I angle my probe very anterior, I actually will probably get a view of the portal veins and the gallbladder as well. So let's go back to the inferior vena cava in adults and kids. There's calculations that we can do using the inspiratory diameter minus the expiratory diameter over the expiratory diameter, and that gives us a collapsibility index. And if it's more than 18%, we say, okay, give some fluids. You can use M-mode for this, and you can use it in ventilated patients. You can also look at the IVC versus the aorta, and if the IVC over the aorta size is 0.8 or less, then they may be dehydrated and you can give them fluids. If the IVC is less than 1.5 centimeters and has total collapse, then I'd say give fluids. Your CVP is probably less than 5. Your CVP is greater than 20 if the IVC is greater than 2.5 centimeters and there's no collapse. A collapsibility index of greater than 75% predicts volume responsiveness. This is an example of an overloaded inferior vena cava. So this person we are not going to give fluids to because they have plenty of intravascular fluid. We see there's no respiratory variation here. It's more than 2.5 centimeters, and this person is going to be volume overloaded. And the other situation that you might see this is in pericardial tamponade. So if you had a large pericardial effusion in this inferior vena cava, I would worry and get cardiology on board sooner. This is an example of your classic medical student or resident who's been running around and hasn't drank anything all day except for caffeine, and we can barely see the inferior vena cava here. It's less than 5 millimeters and it's completely collapsed, and they need fluids. This is another example of somebody who I would give a lot of fluids to. We see with respiratory variation, it completely collapses and it's less than a centimeter. Let's move on to the fast views. And again, this is just a quick look at the fast views while we're assessing somebody with shock or hypotension, and we're trying to figure out what we should do with fluids versus pressors. So we'll take a look at Morrison's pouch, and we'll also look at the left upper quadrant and suprapubic views. We've looked at all of these things, and what a positive fast view tells us is there are 400 cc's or more of blood in the abdomen. Its sensitivity is about 50% for moderate free fluid. So this is not a perfect test, and this is why if we're going to send somebody home after blunt trauma, we're going to do a CT, because a fast exam is not accurate enough to send somebody home based on. The sensitivity for requiring blood or going to the OR is about 70% for the first exam and 93% for the second exam. So if the trauma surgeons use it, it should be as a first of several exams. Where we put the probe for the fast view is we can put them in Trendelenburg for the right upper quadrant and left upper quadrant views, and we can see here where we put our marker dots. It's okay to turn the probe 45 degrees to get it in between the ribs and get rid of rib shadow. For the pelvic view, you can use reverse Trendelenburg to move all the fluid down to the pelvic region when you're looking. So doing the right upper quadrant and left upper quadrant views, you're going to be in the mid-axillary line, and on the left side you're going to be up one rib higher and as posterior as you can get your hand. Your marker dot is up for these views. Again, we're going to use Trendelenburg for the upper quadrants because this is going to increase our sensitivity. To get to see diaphragmatic or pleural fluid, we're going to angle our probe slightly upward and more posterior to get that mirror image artifact. For the suprapubic view, our marker dot is to the right initially in a transverse view. We're going to rest our probe on the pubic symphysis and then angle it down into the pelvis. And we will repeat this exam as often as we need to. So this is an example of a normal right upper quadrant view. We have a nice mirror image artifact where the lung actually looks like the kidney. So this is superior to inferior. This is diaphragm. This is a nice global look at the liver, and this is kidney right here. And we see no black stripe in between liver and kidney. So we say that this is a normal Morrison's pouch view. Here's an abnormal Morrison's pouch view. So our marker dot is up. This is going to be superior to inferior. And we're going to be in the mid-axillary line on the right side. And here we see diaphragm. And above the diaphragm, we see a piece of consolidated lung. And we see a lot of fluid in the pleura. We also see fluid in the peritoneal space here because we see fluid surrounding the liver. So that's a positive fast exam. And sometimes this is where we're going to see the fluid is maybe not necessarily in Morrison's pouch, but maybe we'll see it tracking along the diaphragm here. And then finally, we have the heart here, a piece of the heart, and or more subxi here, and we don't see a lot of pericardial fluid. I wouldn't comment on anything abnormal in terms of pericardial fluid. Here's an example of the left upper quadrant, which is the same view, but again, my hand is resting on the bed. I get the nice mirror image artifact, and I'll get the spleen, which is smaller, and upper rib, and the kidney, and no free fluid in between the two. This is an example of an abnormal left upper quadrant view, and what we see is a little bit of fluid here tracking in between the kidney and the spleen, and here's that free fluid, and all of that counts even though it seems like just a small amount. And then we see this fluid-filled structure with some debris in here, and what this is probably a Diet Coke, and I would guess a Snickers bar all wadded up like this. And I've been doing ultrasound long enough to be able to distinguish Snickers bars and M&M's. So we're going to say this is Snickers bar and Diet Coke. This is another example of an abnormal left upper quadrant. This spleen here looks slightly more hyperechoic, so I would guess that this is a chronic state of fluid in the abdomen. Here we see a piece of diaphragm, a tiny bit of pleural fluid, definitely intraperitoneal fluid here in between the spleen, and we only catch a little tiny bit of the kidney. This is an example of the bird beak sign. Here's the little beak of the baby bird, and what this is a sign of consolidated lung in a large pleural effusion. So this again is the bird beak sign. So it's a left pleural effusion and it's large. When we look at pelvic views, we're going to mostly look at this bladder, and we're not going to be fooled by the internal iliac artery and vein, which will be up here and fluid filled, but they will have significant flow on each side. If we look at a transvaginal view, then we can see the uterus close up here is anteroverted, and the bladder is actually quite tiny. Now, some institutions used to do a transvaginal fast on all women because it increases the sensitivity, but the women weren't exactly into that so much, so most institutions just do transabdominal. Here's an example of abnormal pelvic free fluid. Whenever you see a uterus floating in bowel and hung by the suspensory ligaments, that would be abnormal, and that's a lot of pelvic free fluid. So that whenever you see these fingers of bowel, that's abnormal, and whenever you see the uterus floating in fluid, that is definitely abnormal. Here's an example of bladder, and then we have free fluid surrounding it. Again, this is an abnormal exam. So let's move on to the aorta, because the aorta is something we definitely want to evaluate in somebody who is hemodynamically unstable. And for the aorta view, we're going to start with a subxiphoid transverse view and angle straight down into the abdomen. And the first thing we're going to see is spine shadow. Once we get the spine shadow, we want to adjust our depth to just deep to the spine shadow. So maybe we could get rid of a couple centimeters of depth here to 12 or 13. Just above the spine shadow, we're going to see the aorta. And what we hope to see is an aorta that is less than 3 centimeters. We're going to use the phased array probe or curvilinear probe and measure it at 4 places: the subxiphoid or celiac view, the suprarenal view at the level of the SMA, infrarenal is below the SMA, and all the way down to the bifurcation at L4. The normal diameter is less than 3 centimeters. The sensitivity for AAA is about 100% on ultrasound exam. The sensitivity for dissection is lower, it's 60 to 70%. And we're going to use the anterior right upper quadrant view if the abdomen is too distended. We can also use the cardiac parasternal long axis or suprasternal notch view to see dissection in the arch of the aorta. Again, our technique is going to be to use a 2.5 to 3.5 megahertz curved array or phased array probe. We'll start with maximum depth at 20 centimeters. We'll hold the probe perpendicular to the skin midline. We use the left lobe of the liver as an acoustic window, and we're going to go all the way down to the bifurcation because 95% of aneurysms are infrarenal. And we're going to scan the entire aorta. This again is my favorite view in the body, the backup view. So if the abdomen is too distended, then we're going to go in the mid-axillary line. We're going to angle posterior. The first thing we'll see posterior is the kidney, and as we angle just 5 more degrees anterior, then we'll get the aorta into view. And this again is what we'll see. Here's the aorta right here, which is deep to the inferior vena cava and the hepatic veins. The proximal aorta, here we have spine shadow, here we have aorta, and here we have SMA surrounded by thick white mesentery. Here we see that above the SMA, as we fan superior, we get the celiac trunk. And then this is a part of the portal confluence right here. This is the inferior vena cava. This is an example of spine shadow, aorta, SMA, right here, surrounded by thick white mesentery. Here we're going to have the inferior vena cava giving off the left renal vein in between the SMA and the aorta. Above the SMA, we're going to see portal confluence coming up and around to meet splenic vein. This is a good area to know because whenever we see SMA, we know that it lives right behind the pancreas. So this is actually the head of the pancreas. Now we're going down to about the umbilicus, and we can see that we have bifurcated into the iliac arteries. So 1 to 2, we're at the bifurcation of the aorta. This is an example of a big aortic aneurysm, right? When we measure, we're going to measure outer wall to outer wall. This is a very important thing to remember because a lot of times in an aneurysm, you're going to see a bunch of clot around the edge, and you're going to measure all of that because you're measuring outer wall to outer wall on the aorta. This is an example of spine shadow. Here we see aorta at the level of the SMA, and we see a line going through it, which is a dissection of the aorta. And here we see left renal vein. So this is a problem. Dissection has a very high rate of mortality, and when we see that, we're going to immediately load the boat with our vascular surgeons. For the pleural examination, I like to switch to the linear probe. Some people do use the phased array probe, but we're going to use the linear probe in a long view on the chest wall. We'll start at the third intercostal space bilaterally, and we're going to look for pneumothorax, interstitial lung fluid, or consolidation. And we're going to look at different lines in the lung. A lines are horizontal and normal. B lines are vertical and usually less than 3 per field. The B lines are created by parietal pleural sliding, and they have a negative predictive value of 98% for pneumothorax. This is where we place our probe, and this is what we see. So here we'll see rib, rib, and this is also known as the bat sign. In here we see the parietal and visceral pleura sliding. As you angle more left or right, you'll tend to see more B lines in general. Here we don't see a lot. Here's another example. You may not have a ton of lung sliding if you have pulmonary fibrosis, ARDS, consolidations or adhesions, or right main stem intubation. So these are A lines here in normal lung. This is a tiny, tiny bit of pleural fluid we see above the pleural line right here. So to use M mode for the pleura, we're again going to look at the bat sign, which is the pleura between 2 rib periosteum shadows, which are the wings of the bat. If you see a lot of movement below the pleura, then you're at the beach, and that's good. That's a seashore sign. If you see no lines beneath the pleura, then that's bad. That's called the stratosphere sign or barcode sign, and that signifies a pneumothorax. So on the left, we see the normal seashore with movement below the pleural line. The stratosphere sign, we see no movement below the pleural line. So lung ultrasound for pneumothorax has been studied pretty well. Ball showed that 75% of pneumothoraces missed on supine portable chest x-rays by trauma surgeons. Of those, ultrasound picked up 60%, and if it's a very good ultrasonographer like Dr. Lichtenstein, who's the god of critical care ultrasound, was 95% sensitive. So what we're looking for is A lines plus no sliding has a sensitivity and specificity of 95% when you're looking for pneumothorax. And you can again use power mode to detect slide in subtle cases. Lung point sign is 100% specific for pneumothorax, and that's the area where the lung moves away from the pleura. If you see the pneumothorax more laterally, that's a sign of a larger pneumothorax. Here is what we see. If we have a pneumothorax, we have no sliding at the pleural line. Here we have the lung point sign from here to here, where we start to see lung sliding, and then the lung stops sliding. Here's an example of what interstitial edema looks like. So now we're going to have more than 3 B lines coming from the pleura all the way down to the bottom part of the screen, and oftentimes they widen out like headlights. Lung consolidation looks very speckled. It's also called hepatization because the lung takes on the density of the liver in effect. So let's review the rush exam. The mnemonic for it is HIMAP. The H is the heart, which will look at the parasternal long axis view and the apical 4-chamber view. We'll evaluate ejection fraction. We'll evaluate for pericardial effusion and chamber size. Next, we'll look at the eye, or the inferior vena cava. Is it big or small? Does it predict fluid responsiveness? Next, we're going to look at the Morrison's pouch in fast views and look for free fluid. We will look at the aorta for AAA or dissection. And then finally, we're going to look at the pleura for pneumothorax, effusions, CHF, or consolidation. Even though my lecture was much longer than 2 minutes, you can complete this exam in 2 minutes. And in the words of Theodore Roosevelt, he said, "Do what you can with what you have and where you are." I interpret this as use ultrasound. It's something you can do right away. It's something that you should have at your bedside at most of the time, and it will give you an immediate answer. Thank you.